So I'm going to talk a little bit about women, cardiac complications, and myeloproliferative neoplasms. And I'm going to start by sort of a general important piece of information for women. And that is that you may present with a heart attack a little bit differently than a man does, that women have sometimes different symptoms and that cardiac complications are overlooked in women in general. So the woman at the top is grabbing her chest and that's sort of what you typically think of as a symptom of a heart attack. But women can have more subtle symptoms. The woman below is finding some pain in her jaw, which is intensifying and not going away. Or patients can have back pain. So it's really important as a woman, just in general, to know that you may present differently than a man does, and that it's possible that when you go to an emergency room that your symptom could be overlooked. So that's just an important piece of information for women, and it sort of pertains to the case that I'm going to present. So I'm going to start with a case history because I think it's relatable to all of you as individual patients. So I have a patient who's a 62-year-old woman, and she had no past medical history. In fact, she was in very good shape. She ran in the park every single day and was taking no medications. And she presented to the emergency room of her local hospital with intense upper back pain and left arm pain. And she initially had a workup with, x-rays of her back and her arm. And finally, though, labs were done. And she had a CBC that showed her hematocrit was 57. Her platelets were 540 and her white count was 14. So all of those numbers are elevated. And she had a positive troponin, which is something that we associate with a heart attack. So she then went to the cardiac cath lab, was found to have a narrowing of a major vessel, and a stent was placed, and she was put on Plavix, which is an antiplatelet agent. And she was referred to a hematologist for abnormal blood counts. So a few weeks later, she ended up going to see a hematologist, me, and we went forward and did a bone marrow biopsy where her bone marrow was hypercellular with 90% cellularity, which is much more than you would expect for a 62-year-old woman. She had more red cells than you would expect, small atypical lymphocytes and megakaryocytes with abnormal lobation. A few of them were clustered. Her chromosomes inside the cells were normal, but she was JAK2 positive, and she had an allele burden of 38%. The patient was started on phlebotomy and hydroxyurea, and she required 6 phlebotomies over the next year. And on hydroxyurea, she developed mouth sores, and these mouth sores were very bothersome to her. As a result, she was then started on pegylated interferon, where she had obtained really good count control and did not need any more than 1 phlebotomy while she was on the medication. She had no real side effects to the drug. And she also continued on the medications that were started by her cardiologist at the time of her cardiac cath. Lipitor, metoprolol, a baby aspirin. She was on Plavix for a long period of time, but the cardiologist felt at a certain point that she could stop it. So what causes patients with myeloproliferative diseases to be at higher risk of heart attacks and stroke? This ends up really being just another cardiac risk factor for the development of these ailments. But of course, age is very important. Are you under 60 or over 60? Do you have higher blood counts that are not controlled? Do you have a lot of inflammation, which is also underlying inflammation has been associated with the development of cardiovascular disease? Do you have other illnesses which may predispose you to the development of cardiovascular disease? Have you made really poor lifestyle choices? Are you sedentary? Do you eat a poor diet? Do you continue to smoke cigarettes or maybe drink too much? And what is your gender? Are you male or female? What can be learned from some of the data in cardiovascular disease and MPN patients, and how can we relate this to patients with MPNs? So Interestingly, there was a study looking at the rates of thrombosis in Scandinavian blood donors that was done at the end of the 20th and beginning of the 21st century. And these patients did not have an MPN diagnosis, but they had an elevated hemoglobin. And this was found all by itself just to be a risk factor for arterial thrombosis. This was a large study, 1.5 million subjects, and it confirmed that the rate of thrombosis in patients with elevated hemoglobin is higher than in patients with a normal hemoglobin. And the risk of a heart attack or a stroke is higher in both men and women with an elevated hemoglobin. And in men, the hazard rate of a high hemoglobin was very high, and also for MI and for ischemic stroke. And in women, this was true also. The risk of venous thrombosis was higher in men, which sort of offset this to some degree, but nevertheless, the elevated hemoglobin by itself was a risk factor for arterial thrombosis, and these are in patients who don't have MPNs. Coronary artery disease is driven by other things other than blood counts, certainly high cholesterol and inflammation and high blood pressure, with high blood pressure. Interestingly, there were trials looking at what the relationship might be of underlying inflammation to cardiovascular disease and whether interfering with the inflammatory cascade could improve outcome. In the CANTOS trial, which was done in 2017, there was clinical data presented showing that inflammation all by itself is an important driver of atherosclerotic cardiovascular disease. And the results of this study showed that targeting inflammation with an antibody against something called interleukin-1, which is a cytokine which really increases the amount of inflammation in your body. And that this antibody actually led to a lower incidence of recurrent cardiovascular events as compared to placebo. And this showed that inflammation in atherosclerosis is manifested sort of by the increased presence of immune cells and inflammatory mediators. And if you interfere with this, that you may lead to a lower incidence of recurrent cardiovascular events. Nevertheless, because of certain toxicities and difficulties in getting this drug, this has not actually been mainstream, but it does show proof of principle that interfering in the inflammatory cascade can actually reduce the risk of developing cardiovascular events. Several studies have shown that systemic pro-inflammatory conditions can actually start the cascade of cardiovascular disease very early on in the hematopoiesis of stem cells and progenitor cells. And there's a link actually between high cholesterol and hematologic stem cells, where hypercholesterolemia causes stem cells to proliferate, leading to high white counts and atherosclerotic plaques in both animal models and in humans. So knowing now two things that we have discussed so far, that having a high hemoglobin can actually lead to an increased risk of cardiovascular events, even if you don't have an MPN, and that inflammation is an important driver of cardiovascular events. You would sort of surmise by that information that the rates of thrombosis in MPN patients would be higher. And this was demonstrated in the Swedish Cancer Registry study, where higher rates of both arterial and venous thrombosis occurred across all age groups and all MPN subtypes. And that the risk of arterial thrombosis was particularly high shortly after the diagnosis of a myeloproliferative disease and before there was optimal clinical management. And risk factors for thrombosis in MPN patients that have been determined from the data so far include an age older than 60. Just by turning 60, all of us have a higher risk of developing cardiovascular disease. A history of thrombosis in the past is a predictor of potential cardiovascular disease later on. The concomitant cardiovascular risk factors which may be present in a patient: high blood pressure, tobacco use, high cholesterol, the presence of a JAK2 mutation, the percentage of the JAK2 allele burden may be related to the development of cardiovascular disease. High hemoglobins in PV patients and high white blood cell counts can contribute to the development of cardiovascular disease. And CHIP mutations, which are clonal mutations of sort of an indeterminate significance, are also drivers that can be pro-atherosclerotic potentially, and can be associated with cardiovascular disease. And patients who have higher inflammatory markers or inflammatory diseases like rheumatoid arthritis or other autoimmune diseases where their inflammatory markers are elevated. So in the Swedish Cancer Registry study, they looked at what factors might be important in developing cardiovascular disease, and looking at the Swedish cancer study in patients who had a history of a thrombosis. The risk of developing another thrombotic event was much higher to those with no prior thrombosis. And when combining both age and older than 60, and a history of thrombosis, the hazard rate of developing cardiovascular disease was very, very high. It was 7, so 7 times what we think would be the normal number. The ECLAP study, polycythemia patients older than age 65 had a higher risk of cardiovascular complications, 5% per patient year, or with a history of prior thrombosis, 2.5% per patient year. And the hazard risk for arterial thrombosis in these patients was 1.7 for the age greater than 60, and with 2.1 for those with a history of thrombosis as well. The risk of thrombosis is higher in JAK2 mutated patients with MPNs, regardless of whether you have polycythemia vera or essential thrombocythemia. So JAK2 mutated ET and PV patients have a similar risk of thrombosis, which is twice as high as patients with CALR mutations. And PV patients with JAK2 allele burdens that are high, 75% or greater, have a significantly higher rate of major cardiovascular events and thrombotic events. Primary myelofibrosis patients with CALR mutations have a lower risk of thrombosis than those who are JAK2 mutated. And JAK2 mutated MF patients have a thrombotic risk which is twice as high. And as your MPN, when we consider that as a risk factor for cardiovascular disease, we recognize that controlling the blood counts is actually a way of controlling this particular risk factor for developing a heart attack or a stroke. So controlling the high red blood cell count and the white blood cell count decreases thrombotic risk. So it's a modifiable cardiac risk factor. In the CYTO-PV study, there were 365 JAK2 positive PV patients who were randomized to intensive treatment of their polycythemia vera versus non-intensive treatment using phlebotomy or hydroxyurea. And intensive treatment was defined as those patients where the hematocrit was kept below 45. And those patients had a lower rate of cardiovascular death and major thrombosis than those who had a more loosely controlled hematocrit at between 45 and 50. In the review of ECLAP data, which was a lot of patients, 1,638 PV patients, there were 205 thromboses, and they found that the risk of thrombosis was increased with a white count that was greater than 15. And this was especially true for those patients who had heart attacks, who had a lot higher, with a hazard rate of 2.84. Both white blood cell and red blood cell counts must be controlled to decrease cardiovascular risk in MPN patients. So clonal hematopoiesis all by itself increases the risk of atherosclerotic heart disease. And there was an article by Jayswell et al. In the New England Journal of Medicine in 2017 that was really important. They were looking at patients who had clonal hematopoiesis of indeterminate potential. So it means that there's a mutation in a specific gene, and that this mutation is shared by a number of cells in the bone marrow. This sort of problem is common among older people, and it's associated with an increased risk of developing hematologic cancers, coronary artery disease, and death. And mutations in genes, including DMT3A, TET2, ASXL1, and JAK2, were each individually associated with coronary artery disease. So people maybe with normal blood counts who may carry some of these mutations have an increased risk of coronary artery calcification, which is a marker of atherosclerotic burden. Some of you may have had a CAT scan of the chest at some point in time that was ordered by your primary care or by your cardiologist, where they're looking at your calcium score, which is how much calcified plaque that you might have in your vessels which feed the heart. In 2 retrospective case control cohorts for the evaluation of early onset heart attack, participants who had this clonal hematopoiesis of indeterminate potential had a risk of heart attack that was 4 times as great as those who did not have those types of mutations. And CHIP mutations in patients whose the mutation was a JAK2 mutation had a 12 times the risk of a coronary artery disease compared to those with no mutations. And this is a little cartoon or a graph sort of looking at that. And if you look downwards to the JAK2 mutations, you'll see the hazard ratio, or the risk that could happen is very, very high to the right of that dotted line, which shows really increased risk. And in the bottom graph, you're looking at the 2 different trials where patients who had these mutations, how many of them had myocardial infarction or a heart attack or coronary artery disease according to the different mutated genes. And you'll see JAK2 had a very high rate actually of coronary artery disease and heart attack, particularly in the study in red, which was enriched for patients who had JAK2 mutations as opposed to the study in black. This is a graph really looking at coronary artery calcification scores. So when you have those CAT scans of the chest and they try and determine how much calcified atherosclerotic plaque you might have, you'll find that those patients with no CHIP, did not have as generally as high a score as those people who had CHIP with no, and so you'll see that having a CHIP mutation actually is associated with a higher risk of a high calcium score. And calcium scores greater than this 615 Agatston units show that patients with mutations had a much higher risk developing these diseases, particularly when you look at their VAF score or how much mutation they have. What are the treatment options to reduce the risk of cardiovascular complications in MPN patients? And I show a picture of aspirin, which is a really important ingredient. But to modify your cardiovascular risk factors with an MPN, lowering your white blood cell count, your red blood cell count, and sometimes your platelet count if you're JAK2 positive might be important in lowering your risk of cardiovascular event. And as Dr. Pettit said before, there are many potential options, including hydroxyurea, interferon, and ruxolitinib. She went through this pretty thoroughly, so I'm not going to repeat that, but during the discussion section, I think we can all answer your questions. Anticoagulation or antiplatelet agents also may reduce the risk of thrombus in MPN patients. Aspirin use was validated in the ECLAP study that use of low dose aspirin, which is 81 milligrams in PV patients, prevents cardiovascular events. Coumadin was the sort of the anticoagulant of choice, which has been used to thin the blood. And over an observation period of almost 8 years, there was a 2.8-fold reduction in the risk of recurrence of a thromboembolic event in patients who were on Coumadin without really an increased risk of bleeding. This is important in patients who've had previous myocardial infarctions or coronary artery disease or strokes, that anticoagulation with something beyond aspirin may prevent the risk of developing a recurrent event. There are also new anticoagulants other than warfarin, which is kind of difficult to use because you need frequent blood tests to monitor the dose of the medication. The newer anticoagulants don't require all these blood tests and are dosed in a more, you're given a particular dose and you stay on that dose. And 2 small studies have been conducted to really look at their efficacy in comparison to warfarin or Coumadin. There's not much data in MPN patients, but these are appearing to be equivalent really to Coumadin in the non-MPN population, and is being used with increased frequency in patients with MPNs. There is an important role of statins in the treatment of MPN patients. There's some evidence that statins like Lipitor, for example, or Zetia can downregulate JAK2 STAT5 activation and inhibit JAK2 cell growth all by itself. And statins in the past have actually been suggested as a possible treatment for polycythemia vera. And studies of statins in combination with cytoreductive therapy should be done in high-risk patients for arterial thrombosis. There's a lot of research that needs to be done, I think, looking at cardiovascular risk and modulation in patients who have myeloproliferative diseases. One thing we really don't know is there a value to early aggressive treatment with drugs like interferon in patients with polycythemia vera and ET who are at risk for cardiovascular complications, thromboses, or transformation to AML? But particularly with regard to cardiovascular complications, is it better just to watch your PV patient with phlebotomy and control their hematocrit using this method, or should a more aggressive method like Pegasus be used up front? And that question has not been answered as to whether that more aggressive early treatment might lead to a lower risk of cardiovascular events. We need more information on CHIP mutations. The study that I have recently talked to you about was criticized actually for the number of JAK2 positive patients who were included, where we know JAK2 is actually a risk factor for thrombosis. Well, we don't really know sort of what the molecular causes are of the increased risk of cardiovascular disease and death in patients who seem to have these CHIP mutations, and in patients even with JAK2 mutations. And with patients who have more than one CHIP mutation, and there are some of you out there which may have had molecular studies where you have a JAK2 mutation and potentially a TET2 mutation or a DMNT3A mutation, which are relatively common in older people. Is their prognosis worse? And how do these mutations act together on a molecular basis to increase risk? And can new drug targets be found to decrease cardiovascular risk and early death in these older patients? More specific research on the relationship between cholesterol metabolism and inflammatory pathways needs to be done, particularly in MPN patients who have an inflammatory disease to start with. Are there new targets for treatment, or are there combinations of therapies which may reduce the risk of thrombosis in MPNs and potentially reduce the risk of MI and stroke in patients who don't have these diseases? Bigger studies need to be done on the efficacy of these newer anticoagulant medications to reduce thrombotic risk in MPN patients need to be done. And there's urgent needs for large, potentially international trials to evaluate the use of these drugs in large populations of patients. Cardiovascular disease is the leading cause of death in women in the United States, and it's responsible for 1 out of every 5 female deaths. An outcome can be worse given decreased recognition of symptoms of a heart attack and less aggressive treatments that are given to women in general. And this is important sort of topic to be explored in myeloproliferative disease patients as well. Do we need to be more aggressive in our early treatment of patients with polycythemia vera and ET to improve the outcome of women with MPNs? And the data on early treatment and cardiovascular complications is just not there at this point in time. What can you do specifically to decrease your risk of cardiovascular disease? You need to reduce your cardiac risk factors. So that includes trying to maintain a heart healthy diet with minimal, watching your cholesterol and your saturated fat intake. If your cholesterol continues to be high and diet cannot control it, using statins and PV and ET patients, I think is important. Trying not to lead a sedentary lifestyle. It doesn't really matter, as we heard before, what you do. It's just making sure that you do a little something every single day. So exercise, whether it be yoga, whether it be walking, whether it be resistance training, you should try and incorporate that as part of your life. Treat your myeloproliferative disorder also as a potential cardiac risk factor, and take medication as needed to keep your blood counts under control, or go regularly. Don't skip phlebotomy if that's been recommended by your physician. You need to be in charge of making sure that your blood counts are normalized. And take low-dose aspirin if you have PV or ET and if it's recommended by your physician. Particularly if you're JAK2 positive, you have a higher risk of cardiovascular complication, and a low-dose aspirin is a reasonable treatment for you.